say at the outset that Norman got me a little bit wrong. We don't disagree on obesity. In fact, if he had have listened when he interviewed me in the ABC last time, I sort of suspected, you know, when he asked me a question, then he started dialing up and ordering his lunch when I was answering, that he wasn't listening to me. So what I'm going to do today is, tonight, is try and explain why that is and why we don't think anymore. And I think John Dixon and myself have just written quite a few articles on this recently, why we think now that obesity is a marker for things that are going on in the community rather than a true indication of health risk as such. So let me first set the stage, and some of you will have seen some of these things that I put up, but when you are like this in a new area, you sometimes are in deep shit, so it sometimes is better. But unfortunately, any of you who know me know that I can't do this, so unlike the little guy in the middle, I'm going to have to start talking. I'm going to make three main points. The first is, why do we need yet another new approach in primary care? And I thank Norman for his comments too, but we are not, in this area of lifestyle medicine, we're certainly not trying to take away from conventional medicine. We're trying to add to what happens in conventional medicine. That's the first issue that I'm going to address. Secondly, is there an underlying biological basis to what is essentially behavioural, environmental etiology of chronic disease? And that's where we get into this new area of inflammation, chronic systemic inflammation, which I think now explains a lot that we didn't know just a few years ago even. And finally, I'll talk a little bit about lifestyle medicine, where it does fit into conventional clinical public health dichotomy, and what does it add to conventional pharmacomedical treatment. So the first question, why the need for yet another new approach in primary care? Well, I'm going to sort of draw a big bow here, and this is an area of my particular interest at the moment, is linking health and modern health, and with my background is sort of basically epidemiology, trying to look at the causes of disease over time, with economics. And these two sciences, if you call economics a science, have been separated for so long, and yet economics is supposed to create well-being for the community. Traditionally, we've thought, and it's been shown quite clearly in developing countries, that there's a close link between economic growth and human health. And it was always thought that the link was one-to-one, as it is shown on this graph here. And in fact, some of the writers in this area, some of the medical sociologists, have said that economic growth has been the single biggest contributor to human health, particularly since the Industrial Revolution. But if you take that right back to the beginnings of time, there's no doubt that economic growth has been the single biggest contributor. So what's going wrong? What's going on here? Well, interestingly, I did have a major in my first degree in economics, so I've got an interest in economics, and I wrote a paper back in 1978 on economic growth and on economic growth and human health, and I talked at a conference in Denmark on that. I happen to be the only person there saying that there's a potential problem with this, that you can't grow forever, and that because economic growth, as it's measured through GDP, is made up of figures such as figures for smoking, for drinking, for drug use, and also those figures that go into surgery for treating the smokers and the drinkers and the drug users, go into gross domestic product, then there has to be a point where you say, well, this is not a good measure of what's really going on in the community. There's a few economists in the world who are looking at this, very few, because the economics profession really isn't interested in human well-being as a whole. One of them is a guy called Jose Tapia Granados from Michigan University. He's done studies on a lot of different countries, and what he's found is that with the economic growth cycle, if you can see here, the yellow line is economic growth, and it goes up and down in what's traditionally called, in an ironic term, the business cycle, goes up and down. And when you look at mortality, which is probably the best long-term measure that we've got of health, it's anti-cyclical with the growth cycle. In other words, when we are going well economically, we are going bad physically, and when we are going bad economically, we are going good physically. And there's a lag time, so that you can see here, in the good economic times, it takes a little while, but the health improves. Mortality decreases dramatically, health improves. When we go bad economically, health increases. And we're seeing this, we're in right at the early stages of witnessing this with what's called the GFC, the global financial crisis. And where that takes us is going to be interesting. I've just responded to a paper in the American Medical Journal which said that this is disastrous because we're going to have more fat people and we're going to have more ill health as a result of the recession. Tappy Granatus and myself responded to that by saying that's nonsense. If you look back at all the recessions throughout history, health has improved in the recession. If you look at the book that's written by David Potts in Victoria on the Great Depression, people were better in the Great Depression, were healthier in the Great Depression than they were before the Great Depression. True, in the first year, 1930, suicides went up. After that, they dropped below the levels of the 1920s. They were the stockbrokers in the 1930s. So there's something funny going on here with economics and health. And it was shown quite clearly in a study published in the American Journal of Epidemiology 2 years ago now. Tappy Granatus was one of those working on this. This was done in Cuba when the Russians left Cuba. And they left the Cubans bankrupt, basically. So from 1990 to 2000, the Cubans had no economic growth and no economic benefit. This team of American epidemiologists and economists went in and looked at health over that time. They found that for the first time, this is one of 4 instances that I know in the world, obesity reduced in that 10 years. And you can see the shift in the normal curve from the right to the left as the overall obesity decreased by 20% in the Cuban population. If you look then at the disease rates in that 10 years, those diseases that respond quickly to changes in lifestyle, type 2 diabetes, for example, coronary heart disease, all-cause mortality dropped within that 10 years. 20% heart disease rates, about 18% stroke, decrease in stroke, and about a 20% decrease in overall mortality as a result of going broke. Now, the reason for that was that Cubans were eating 1,000 calories a day less than they were before the Russians left. They were eating, before the Russians left, they were eating 2,800 calories a day. That's not army rations. That's it's quite good. We eat, the average male in Australia eats 2,400 calories a day. The average female about 1,800 calories. So 2,800 calories was quite good. They dropped by 1,000 calories, their health improved. And we've seen this around the world. We've seen it during the Second World War. We've seen it in Sweden. We've seen it in Japan. Tappy Granatus has just published a paper in Ireland and England, the same sort of thing. So something funny is going on. We are getting a decrease in deaths from all causes over time. And that's what we seem to associate with economic growth and economic development. That decrease has come largely from a decrease in acute diseases, infectious diseases. But what we are just starting to see, we're well into it in Australia at the moment, but in developing countries we are just starting to see a crossover between acute diseases and chronic diseases, which is called the epidemiological transition. That's really the sweet spot in a country's development. And if you said in health terms, maybe that's where we should stop developing, because that's where the chronic diseases take over from the infectious diseases. Now, admittedly, we are living longer. We are still living longer in general. But because we now don't use mortality so much as a measure of health, we use years of disability-affected life years, or years of disability, then you can see we are living longer, but we are living longer with disability. And is that the function of what's happening in the economic system? If you look at the 15 leading causes of disability-affected life years in Australia, it's quite different to when I started in the health department in epidemiology 30 years ago, where we used to look at mortality and we said, well, heart disease is the biggest problem, then after that is cancer, then so on. But if you look at disability-affected life years, it's quite different, because we've got things like depression up there, dementia, diabetes. Now, these don't kill you immediately, but they are certainly causes of disability which make life pretty difficult if we exist with them. So what seems to be happening is this, that economic growth up to a point is effective in reduction of disease. But beyond that point, economic growth by definition means we're producing plastic ducks, basically. Plastic ducks for no purpose other than the sale to somebody else of that plastic duck. And in doing that, we are not only affecting our own health because of the technological changes and the changes in nutrition and so on that occur with that economic growth, but we are affecting the environment, as we'll see in a little while. I'll finish off with that in the session. So, looking at this from a true epidemiological perspective, you don't just look at the diseases, you look at the you look at the risk factors for the diseases, and quite often in clinical practice that's where you stop, you treat those risk factors. But really, from an epidemiologist's point of view, if you're an acute disease epidemiologist and you get an